Okay, now we start. We continue with the embryogenesis that we were talking about. We have already discussed the first 2 weeks, but just to recollect where we were, I'm going to just give you a brief revision of what we have already done. In the first week, we said oogenesis took place, that is, all the gametogenesis processes occurred. Then we had the spermatogenesis, which occurred, then the deposition of the sperms in the vagina, which entered the uterine tube. There, fertilization occurred. Second meiotic division was completed. Female and male pronucleus formed, then enlarging and then meeting as the next the zygote was formed. You can see all these stages, and then there is the blastomeres. They start to the multiplication started, that is the mitotic division started after the fertilization, the two cell stage, and four all those morula, and then the blastomere was formed, and then there is the formation of the blastocyst. All this was occurring in the ampulla, and then going onwards towards the body cavity of the uterus. There it was starting to implant. Then in the second week, the blastocyst was partially embedded in the endometrial stroma, and the changes in the endometrium was known as the decidual direction. That is, it was a preparation for the blastocyst to come, or for the developing embryo to be supplied by nutrition. Then the trophoblast also divided into two stages, the sensitive trophoblast and the cytotrophoblast. Then what exactly happened in the second week was, the second week, as we have already said, that it is a week of tubes, and because everything divided into two things. The trophoblast, first we talk about, it differentiates into the two layers, that is trophoblast and the syncytial trophoblast. Then we said the blastomeres, they divided into two, the inner cell mass and the outer cell mass. The outer cell mass was the trophoblast, which was cytoblast and syncytial trophoblast. Then the embryoblast, that is the inner cell mass, that is going to again further divide into the epiblast and the hypoblast. Epiblast is the upper layer and hypoblast is the two layer. Then the extraembryonic mesoderm, that was developing on the outside, that is on the inner side of the cytotrophoblast. That lining of the mesoderm that developed, that was called the extraembryonic mesoderm, and this was then dividing into two by the formation of a cavity which we called as the blastocele. That cavity, which covered the whole of the both the embryo and the yolk sac, amniotic cavity and the yolk sac, that is the outer one, that was called as the spermatophoric mesoderm. And that which just covered the yolk sac, that was called as the splanchnophoric, that is the viscera individually, that is both the amniotic cavity and the yolk sac, that was called as the splanchnophoric mesoderm. And that which covered on the outer side, that was on the outer wall of the cyst, that was the somatophoric. Then we divided, the two cavities were formed. One was in the epiblast, that was the amniotic cavity, and then it was the yolk sac, that was the inner lining by the Hauser's membrane on the inner side of the cytotrophoblast, which lined a small cavity which was called as the yolk sac, or the vitelline cavity, or the yolk sac cavity. Then this, so that was all what we have reached up till in the second week. Then the at this time, the cessation of the menstruation is the first indication that the woman may be pregnant or maybe has conceived. Normal pregnancy can be detected by ultrasonography, or we said that the HCG, which can be tested in urine. That was the chemical which was tested for the pregnancy test, the earliest pregnancy test. Symptoms are frequent symptoms: nausea, vomiting, maybe there, may not be there, slight loss of blood or trickling of blood at the site of implantation. When we said that the blastocyst is embedding into the uterus, there when it the sinusoids and your these lacunae, they come in contact with each other, there may be a small amount of trickle of blood that can lead into the slight amount of bleeding that were at the implantation site. Then we go on to, so that is what we have reached up till now. So it is confirmed that the mother is expecting, and these are the changes which have occurred by now. That is, the embryo has implanted, and even by the ultrasound we can detect the follicle or the ovum that is there. Then is the third week of development. That is the third week of development of the we still talking about the embryonic development. We said till the 8th week or first 3 months is the embryonic time of development. Now the third week of the embryonic development, first is after second, that is the first missed period, that is after 2 weeks, that is the third period. In this, what happens is the formation initially we had formed two layers. That was the bilaminar disc, and that bilaminar disc was basically your epiblast and the hypoblast, which are further gradually going to be converted. Epiblast will become your ectoderm and hypoblast will become the endoderm, and then we are going to deposit a layer what we call as the intraembryonic mesoderm, which is going to be the definitive mesoderm and which is going to become continuous with the extraembryonic mesoderm, which was covering the outside. So the formation of the germ layers and the early tissue and organ differentiation is going to occur in the third week. The development of the embryo from the embryonic disc. Embryonic disc was basically your inner cell mass, that is epiblast and your hypoblast together there, that is what they form a disc-like structure. So that is what is called as the embryonic disc in the third week. That is going to give rise to appearance of something what we call as the primitive streak, which develops further into the notochord, and then differentiation of the three germ layers. Notochord is basically the axis in the center which is going to give around the stability of the structures which are going to develop around the center of the body. First process is gastrulation. Gastrulation is the bilaminar embryonic disc. That is what we said was, that is the epiblast and the hypoblast. That is the inner cell mass. This was bilaminar. This is now going to convert into a trilaminar amniotic disc. This conversion of the bilaminar disc into a trilaminar disc is what we call as gastrulation. Now, how does that occur? If you see all this, this was the initial picture, that is still where we are in the embedding the maternal blood chorion. That is the chorionic cavity which was there. Then there is the allantois, you have the yolk sac, you have the amniotic cavity, and then the endometrium. Most characteristic development during the third week of gestation is gastrulation, the formative process by which the three germ layers or the precursors of all the embryonic tissues, that is endoderm, mesoderm, and ectoderm, develop, and the axial orientation are established. That is all gastrulation. The axial orientation is basically the development of the notochord. Establishment of three germ layers is ectoderm, mesoderm, and endoderm. The bilaminar embryonic disc is now converted into a trilaminar amniotic disc. Gastrulation, what happens is, beginning with the formation of a primitive streak. Let me see if I should show you this line in the center. If this is seen with the section, this white portion is the cut of the, we've cut off the head is the amniotic cavity, and we are looking from the top. That is what we are seeing is the epiblast. That is, this blue structure is your epiblast, and we have cut the amniotic cavity which was there on the top of it, and the epiblast formed part of your aminoblast which lined the amniotic cavity. Now we're looking at it. So this, and the anterior end, that is the cephalic end, this end is the caudal end, whereas the posterior end, oropharyngeal membrane is your cranial end, and the, or you can call it the cephalic end. And as I told you, cephalic and caudal is the term used when the development is taking place, just to specify. We don't use the term head and foot because nothing has developed as yet. So just to be more specific at what side we are developing or what we are talking about, we talk about the cephalic end. Cephalic end is where the head is going to develop, and caudal end is the end which is the posterior end. So in this case, in this picture, as you see, the caudal cephalic end is there, the oropharyngeal membrane, as the name is telling you, that is the part where you are going to develop your oral cavity, or the head is going to develop. And cloacal membrane, this posterior end, this is going to be where the anal canal and the external orifices are going to develop. So when you see this blue structure, that is the epiblast, you see something in the caudal end, this structured a line-like thing, which is what we call as the primitive streak, which does not go till the end of the oropharyngeal membrane, but it is roughly midway between it. So that is the appearance of the primitive streak, that is a line into it, right? The face of the surface of the epiblast. The cephalic end of the streak, that is the primitive node, that is this end, that is the more dilated sort of a thing, that is known as the primitive end. Now this, though we are talking about the caudal end of the embryo, but still we have separate cranial and caudal ends of the cephalic or the caudal ends of the primitive streak, because it finishes, this primitive streak finishes in the mid of the whole of the embryo, the disc. So that is why its caudal end or the will be at the back, but the cephalic end would be in the middle. That is roughly what we call as the primitive node. So primitive streak is the line, and so that nodular structure at the cephalic end is going to be called as the primitive node, if you see it in this picture. right? The cephalic end of the streak, the primitive node, consists of a slightly elevated area which is surrounding and there is a small depression in this node, which is called the primitive pit. Cells of the epiblast from the sides, they are going to travel inwards into this streak. Cells of the epiblast migrate towards the primitive streak, detach from the epiblast and slip beneath. So that means the epiblast cells from the sides, they're going to travel towards the primitive streak, enter into it, and then spread out underneath this primitive streak, and they are going to detach from the epiblast. This inward movement is known as invagination. If you can see this picture in this is the primitive streak. That was the lower picture. As you can see, that is the primitive streak, the node, and the blue is the epiblast. These cells are invaginating at the level of the streak, these red ones, and then they are spreading out onto the left and the right side, and they are spreading out. This is going to develop into what we call as the intraembryonic mesoderm. So these cells, they are going to, epiblast is then going to become the ectoderm. The yolk sac or the cells below, they are going to become the endoderm. And if you see this lower picture, you see the primitive node, then you have the primitive streak, and then you can see the primitive streak epiblast cells and hypoblast, and then these cells which are going to enter into it and they're going to detach, so separating out the epiblast and the hypoblast completely, and then forming another layer in between these two, and that is what we are going to call the mesoderm. If you see in this picture, the node, the streak, cells entering from the epiblast. The blue is the epiblast, yellow is the hypoblast. So, and then this red ones, these are going to enter from the epiblast, spread out left, right. So we're getting a trilaminar structure. The blue is going to become the ectoderm, red is going to become the intraembryonic mesoderm. Be very clear, because extraembryonic mesoderm was on the outer side. And then we have this yellow, which is going to become the endoderm. Okay. So this process by which the cells are going inwards, that is called the invagination. The cells invaginate, some displace the hypoblast, creating the embryonic endoderm. So below it becomes the endoderm. Some come to lie between the epiblast and the newly created endoderm to form the mesenchyme. They become the mesenchymal, those red cells. Mesenchyme forms the mesoblast. Undifferentiated mesophyte forms the intraembryonic or the embryonic mesoderm, and cells remaining in the epiblast then form the ectoderm. So hypoblast becomes endoderm, they become the mesoderm, and the cells remaining in the epiblast which do not migrate inwards, they're going to become the ectoderm. These three layers give rise to all of the tissues in the organs in the body. If you see this picture, you can see again the primitive knot, streak, the cells. It's a diagrammatic picture representing what all is going inwards. Then if you see in this, three layers are going to form. The ectoderm forms the epiblast. If you see nervous system, and basically because that's going to be on the outer side, and this is going to be the epidermis. Endoderm forms the hypoblast, which is going to be the gut cells or the organs which are there, and mesoderm, which is going to be your everything else, that is the rest of the structure. Then you have this blastocyst. The blastocyst, these basically show you the structures which are going to develop from the ectoderm, endoderm, and the mesoderm. This again shows you how the cells are forming. That means this becomes the ectoderm, yellow becomes the endoderm, this red becomes the mesoderm. This is what we're going to show you when we form the somites, intermediate mesoderm, and lateral plate mesoderm, the three parts of it. The cells move between the epiblast and hypoblast layers, spread laterally and cranially contact with the, then ultimately as they go forwards and on the sides, they become in contact with the extraembryonic mesoderm, which is covering both the yolk sac and so it becomes in between, and it reaches to the lateral ends of the embryo, developing embryo, and there is going to come in contact with the extraembryonic mesoderm. It's going to pass also into the anterior pine or the cephalic direction. It passes on each side of the precaudal plate, or what we call as the buccopharyngeal membrane. I'll show you this picture. This plate on the end, if you see this oropharyngeal membrane, this is the main or the oropharyngeal membrane. This is going to become basically your oral cavity. The cells are going to go forwards into this up till this layer, and then they're going to go on either sides of it. Now at this point, the oropharyngeal membrane and the cloacal membrane, what happens is that the ectoderm and the endoderm, they are fused together, and it's not the mesoderm which can separate these two structures. So that point, these nodular structures where the ectoderm and the endoderm, they are in contact with each other, and the mesoderm layer cannot separate these two layers. That is the point which at the cephalic end we call it the oropharyngeal membrane, at the caudal end we call it the cloacal membrane, right? So in the cephalic direction, it passes on each side, because I've told you it cannot separate out the precaudal plate, which is basically your buccopharyngeal membrane. Some endodermal cells where ectoderm and endoderm fuse, and that's going to become your oropharyngeal membrane. The precaudal plate important for induction of the forebrain, and this is where you form the oral cavity. Then the oral pharyngeal membrane is the cranial end of the disc, a small region of tightly adherent ectoderm and endoderm cells, which are oral cavity. Caudal to the primitive streak is a circular area, again as I've shown you, the cloacal membrane, which shows you the site of the anal canal. This again is where the ectoderm and the endoderm, they are held together. So the middle of the third week, intraembryonic is going to separate both the ectoderm and endoderm everywhere except at the oropharyngeal membrane and at the cloacal membrane, and in the median plane cranial to the primitive node where you develop the notochordal process, what we're going to talk about just now. At these three places, the ectoderm and the endoderm, that is adherent to each other. Otherwise, the mesoderm is going to separate out these two layers. Now, if you see in this, that is the oropharyngeal membrane, the cloacal plate, and this is the oropharyngeal membrane. As you can see, the ectoderm and the endoderm, they are fused together. This again is ectoderm and endoderm is fused together. Now, notochordal process and notochord, that is the development. Some mesenchymal cells through the streak, they migrate cranially from the primitive node and pit, forming a median cellular cord, the notochordal process. That is this, entering into the pit, then going forwards till this precaudal plate, then this is what we call as the notochordal process. This is the cells, the nodular, the cord-like structure, which is called as the primitive notochordal process, a median cellular cord. It first it is solid, then it obtains a cavity, then it is called the notochordal canal. This notochordal process grows cranially and reaches the precaudal plate. If you can see this, this is first solid, then it obtains a lumen that becomes the notochordal canal, and this canal is going to lead the precaudal plate, that is the plate where you have the three layers of the mesoderm, that is precaudal mesoderm, that is there a precaudal plate, that is where you have the oropharyngeal membrane or the precaudal mesoderm. It reaches till that level. See in this picture again, if you see this, this is going to the entry notochordal process under the ectoderm. Again, if you see this from the pit, these cells are invaginating. First, it is going to be solid, that is the notochordal process. Then it contains, if you see the solid part is called the notochordal process. Then in the center, it requires a lumen. That part is going to be called the notochordal canal, and it's going to reach the part where ectoderm and endoderm are fused, that is the precaudal plate. It's going to reach till that part. And ultimately, this whole of it is going to be containing a canal, and that is going to be called the notochordal process. Then the notochordal process elongates. If you see this, these are the gradual steps which are going to occur. The notochordal process elongates by the invagination of cells from the primitive pit. The pit extends into the notochordal process, forming this notochordal canal. The process is now a cellular tube that extends cranially from the pit to the precaudal plate, if you can see in this E picture. Then the floor, in the next step, the floor of the notochordal process. If you see, this is the notochordal process, the red, that is of the mesenchyme. This is from the pit, the cells are invaginated, they become the canal. This is the epiblast or the ectoderm, the yellow is the endoderm. Now it is a luminous structure. The floor of the notochordal process, that is these arrows show you the floor of the notochordal process because it is a canal-like structure, fuses with the underlying embryonic endoderm, with this endoderm undergoing, and then it goes under degeneration, and the result is that there is no floor anymore. Openings in the floor of the notochordal process, the notochordal canal into communicate, and then there is communication from the amniotic cavity from the canal into this yolk sac. There is this because the floor is dissolved away, and so the process, the notochordal canal, into communication with the umbilical vesicle, or what you call as the yolk sac, because the floor layer has disappeared. Proximal part of the notochordal canal persists temporarily. This small portion, this canal is there. This is what we call as the neuroenteric canal. This small process is going to be there, the canal, because this is just finished. You just have one straight line, just as the mass of the cells, because the canal is no longer a canal because the floor has dissolved away, and that becomes a continuity between the notochordal canal and communication with the umbilical vesicle. Proximal part of this canal is still persisting, and that is what we call as the neuroenteric canal. You can see in this arrow. The openings rapidly become confluent and the floor of the notochordal canal disappears. The remains of the notochordal process forms a small plate. This is then what we call as the notochordal plate. So first we had the notochordal process, then we had the notochordal canal, and then this canal had the floor which dissolved away and which just left a small plate, what we called as the notochordal plate. This one in the C picture, because there is no floor, and this small initial portion of the notochordal process, that is what we call as the neuroenteric canal, because in that portion the canal still persists, whereas the lower portion, it's just a plate. That remains of the notochordal process forms a flattened groove called the notochordal plate. This notochordal plate is then going to give you a U sort of a structure, and this U sort of structure is then going to fuse together and it's going to form the notochord proper. You see this, the beginning at the cranial end of the embryo, the notochordal cells proliferate and the notochordal plate infolds. If you see, this was the center portion. This was the rest of the mesenchyme. The F picture, if you see, E is the initial one, that is, this is the plate. That is the notochordal plate. This is the neuroenteric canal. And in the F, then this plate is going to form a U-shaped structure, and then ultimately these U-shaped corners, they're going to meet, and that is going to what we have the, you can see the notochordal plate is enfolding, and then we develop what we have, the notochord. So this is the enfolds to form the notochord. This brown becomes the same thing as the red. When it enfolds, it forms the notochord, and ultimately the final thing is that we have it over here. That is, it becomes the notochord. Now, just to recollect all what we are talking about, first we said that we had the pit and the streak. From the streak, the cells of the epiblast, they invaginated and they spread out on both the left and the right side, forming the intraembryonic mesoderm. The ectoderm was the epiblast, and the hypoblast was your endoderm. Then these cells, they reach, this is called the notochordal process. This process reached up to the precaudal plane. That is where you have the buccopharyngeal membrane. Then this develops a canal into it, that is called your notochordal canal, or the canal developed into it that reached up till the notochordal precaudal plate. That precaudal plate is where your ectoderm and endoderm, they are fused together. So this is the process. Process becomes the canal because of the lipid which is extending up till the end. Then if you see in this again, the primitive pit, the canal, this small process, where it is solid, it is called the notochordal process, and where you have this canal into it or a lumen into it, we call it the the notochordal plate canal, right? Then if you see in this picture, this is the intraembryonic mesoderm. This is the notochordal canal, and the rest of it is the notochordal process. Then this initial portion is going to be called as the neuroenteric canal, because when this fuses, the floor of this notochordal canal, it fuses with the hypoblast or the endoderm. This is going to, these arrows show you that this is going to dissolve away. The floor of this canal is going to dissolve away along with this portion of the endoderm, which makes a continuity between the canal, neuroenteric canal, and the umbilical vesicle, or you can say the yolk sac. Then this part of the floor has dissolved away, but this portion, which is the other part of the canal, that is going to red, this is going to be called as your plate. This is just a plate like structure, and we call it the notochordal plate. This is then given the name as a notochordal plate. This notochordal plate is then going to form a U-shaped structure. This brown structure is the same as the notochordal plate. This notochordal plate, which becomes a part of this in the endoderm, which has been intercalated in the embryonic endoderm, so it becomes a part of this endoderm. This then invaginates, as you can see, This comes invaginated, and this is going to form a U-shaped structure. Ultimately, this is going to close down, and it is going to form a tubular structure. This is plate infolds to form the notochord. When the development of the notochord is complete, the neuroenteric canal, this is going to finish off. This is going to form the notochord. The notochord becomes detached from the, this is going to be separate. As you can see, yellow is separate, blue is separate, and this brownish or the pinkish, that is going to separate out, and this is what we call as the notochord, detached from the endoderm of the umbilical vessel, which again becomes a continuous layer. If you see in this G picture, this becomes again continuous. This is what we call as the notochord. The notochord extends from the oropharyngeal membrane to the primitive node. That is, it was this primitive node, or the started because it formed from there, and this is going to extend till the oropharyngeal membrane. The notochord degenerates. Small part of it is just going to persist, which is going to become the nucleus pulposus, part of the intervertebral disc. Otherwise, the whole of the notochord is just going to degenerate. The notochord induces the ectoderm to form the, start the formation of the neural plate. This neural plate is going to start as the development of the neural tube, and this is going to form your central nervous system. Notochord induces the overlying embryonic ectoderm to thicken and form the neural plate, the primordium of the central nervous system. You see in this, this is the pit, neuroenteric canal. This is the notochord, which is there till the precaudal plate. Then this intraembryonic mesoderm on the side. This is endoderm. This is going to form a U-shaped structure. This U-shaped structure is going to separate out from the endoderm. This is going to be called as the notochord. And this is the intraembryonic mesoderm. This becomes continuous on the sides. With this, what we have is the extraembryonic mesoderm. So development of the notochord goes into these steps. Pre-notochordal process, proliferation of cells from the primitive pit forms a cord of cells in the median plane till the procaudal plate. Then notochordal canal canalization, forming the notochordal canal. Then fusion between the floor of the canal and the endoderm. Then you have the entire, this neuroenteric canal. This is the temporary communication between the amniotic cavity and the yolk sac, because the floor of the canal has degenerated, and it's, that is, there is a direct communication from the amniotic cavity through the pit to the neuroenteric canal, and then into the yolk sac. Degeneration of the floor of the notochordal canal underlying endoderm. Definitive notochord is regeneration of endoderm only, and rest is the inverted structure of this part of the central portion of the neural plate, that the notochordal plate, that is going to form the definitive notochord when it forms enfolded on itself. What does notochord do? Signals from the primitive streak induce the notochordal precursor cells to form the notochord, a cellular cord-like structure. The notochord has defines the primordial longitudinal axis of the embryo. It gives some rigidity and development signals that axial musculoskeletal structures and the central nervous system starts to develop at this level. So it provides the signals necessary for the development of the axial musculoskeletal structures in the center and the central nervous system, and it also contributes to the intervertebral disc. We've said the notochord is going to degenerate. Otherwise, just small nucleus pulposus part of the intervertebral disc is going to form by it. So basically, it gives you the longitudinal axis for the structures to develop. It gives the body a rigidity, and also the development stimulates this development of the central nervous system by activating the ectoderm to form the neural tube, and then the development of the axial certain musculoskeletal structures. All this is the central part of the notochord which is doing. Then in the third week, what we have is that the bilaminar embryonic disc is converted into this trilaminar amniotic disc. That is what we called as the gastrulation thickening of the epiblast at the caudal end of the embryo. At the primitive streak produces mesenchymal cells. Epiblast is known as ectoderm. Epiblast displaces the hypoblast, which are going to be called your endoderm. And then we had in the center, we had the intraembryonic mesoderm. And mesoderm, between the ectoderm and the everywhere mesoderm is going to separate the two, as I've already told you. Only the plates at the anterior end and the posterior end, where the ectoderm and endoderm, they are going to be fused. That is anteriorly, it is going to be called as the oropharyngeal membrane, or where you can say it is near to where we have the precaudal plate. And at the posterior end, where these ectoderm and endoderm are fused, still mesoderm cannot separate the three layers. This is called the cloacal membrane. Early in the third week, mesenchymal cells form the primitive streak from the notochordal process between this ectoderm and the endoderm. Notochordal process extends till the precaudal plate opening develops in the floor and leaves the notochordal plate. This notochord briefly is how the notochord is forming, and this unfolds to form the notochord, which is basically the primordial axis of the embryo around which the axial skeleton forms. Then it is going to stimulate this formation of the central nervous system. This is the precaudal plate, the caudal end, the primitive streak forms, then the newly added cells, then is the node, then this ectoderm that is going to form this development of the neural plate. That is the epiblast. Epiblast becomes the ectoderm. Ectoderm is then going to form the neural plate, and neural plate is then going to have a dip inside it, which is going to form a cleft, and cleft these plate is going to rise together, and these two are going to fold together and form this neural folds, and neural folds are ultimately going to give rise to your neural tube. And this blue is the notochord. It's said to stimulate the development of the CNS. Then, what is the fate of the primitive streak? Primitive streak actively forms the mesoderm until early part of the fourth week. Then production of the mesoderm slows down. It diminishes in size, insignificant in structure. It is a primitive streak, and in the sacrococcygeal region, normally the primitive streak undergoes degenerative changes and disappears by the end of the fourth week. Then fate of the notochord is, as I've told you, it's just the nucleus pulposus. The rest of the notochord is going to disappear. Remnants of the notochordal tissue may give rise to something as a tumor, what we call as the chordomas. These are the chordomas. So if you can see this part, the nucleus pulposus, that is the annulus fibrosus, and this nucleus pulposus in the center of the intervertebral disc. This nucleus pulposus is developed from part of the remnant of the notochord, and at times part of the notochord persists, and that gives rise to something what we call as tumors, that is called the chordomas. Remnants of the neurochordal tissue, being it can be benign or malignant, and that is called the chordomas. These occur at the base of the cranium, extend into the nasopharynx. Slowly, it may be benign, but it may convert into being malignant and infiltrate the bone. Most commonly, these are seen something as what we call as the sacrococcygeal teratomas. Remnants of primitive streak may persist, and most common site is the sacrococcygeal remnant. That is why these are called the sacrococcygeal teratomas. They derive from, because the primitive streak has layers cells which are from ectoderm, endoderm, and mesoderm, all these three. So that is why we call them the pluripotent. If you remember, that's from the site where it is developing. These streak cells, these tumors contain all sorts of tissues, because the all three types of epithelium is present in it. So the streak has cells from the three germ layers, so that is why it is derived from pluripotent preset. So that is why the tumor that is going to appear is going to contain all sorts. So the tumor can be of ectodermal origin, it can be of mesodermal origin, or it can be of endodermal origin. That is what exactly is meant. It is pluripotent. These tumors contain tissues that are derived from all three germ layers in complete stages of differentiation. So most common tumors in the newborns, and then about 80% in the females. Diagnosed on routine antenatal ultrasonography, most tumors are benign, they can be excised, and the prognosis or the result is good. You see this is what we call as the sacrococcygeal teratoma, because they are more common at the level of the sacrum and the coccyx vertebra. Pterogenesis associated with gastrulation, what can occur third week of development when gastrulation is initiated, is a highly sensitive stage for teratogenesis, because still differentiation is going on. Always remember, when the phase of differentiation is going on, changes of malignancy or teratoma or can are very highly sensitive due to any cause. Fate maps can be made for various organs. Doses of alcohol at this stage kill cells in the midline of the disc, producing deficiencies in the midline craniofacial structure, resulting in hollow prosencephaly. That is the uh, development of the brain is not there, that is hollow. So all these abnormalities can be there. Any germ layer can be affected. Gastrulation may be disrupted by the genetic abnormalities and the toxic insults. Caudal dysgenesis is insufficient mesoderm is formed in the caudalmost region of the embryo. This mesoderm contributes to formation of lower limb, genital, all these things. So affected individual in varied lane. That is caudal dysgenesis, that is in the lower part, the mesoderm, which is forming at this gastrulation, because we have already have the two layers, but in the third week we are forming the mesoderm. So any abnormality which is going to occur at the level of the mesoderm is going to give you the abnormality. This mostly affects the lower portion. That is why it is called the caudal dysgenesis, affecting the lower limb, urogenital system, lumbosacral vertebra. So at this level, this most commonly causes the abnormalities. You can see all these abnormality is caudal dysgenesis, because this is occurring at the lower level, most common site where it is affected. So you can see it has affected the limbs, it has affected the other parts. Situs inversus can occur as a condition in which transposition of viscera, that is left viscera goes to right and right goes to left in the thorax and abdomen, can occur. Laterality sequences, patients with these conditions do not have complete situs inversus, that is it's not necessary that everything is on the opposite side, that if supposing the one lung is on the or the kidney is on the left, is on the right, right is on the left, it's not necessary that all the structures from the top to bottom should be the on the opposite side. It can be a mixed arrangement. That is laterality sequences. Sometimes remnants of the primitive streak persist in the sacroregional clusters, proliferate and form sacrococcygeal teratomas. Then you have something in this area, that is the allantois. I show you this picture. This is what is called the allantois. This is a tail-like process or a finger-like process or a finger-like diverticulum on the posterior part. This is called the allantois. 16th day, a small sausage-shaped diverticulum from the caudal wall of the umbilical vesicle that extends into the connecting stalk. And that connecting stalk was that area where we said the extraembryonic mesoderm was forming the cavity, the chorionic cavity all over, but only a small place where the bilaminar disc was connected to the outside, to the chorionic plate through this, only this small part. And this small part was what we call as this umbilical cord or the connecting stalk. This connecting stalk is where it extends, this allantois extends into that. The allantoic stalk remains very small, but the allantoic mesoderm forms blood vessels that will serve the placenta. The original part of the allantoic diverticulum persists as a stalk called the urachus, from which this develops from the bladder to the umbilical region, and called the urachus. And then this persistent stalk, and it may have a communication, and if this stays patent, this sausage-like structure, this is going to have a communication between the bladder and to the umbilicus, and through the umbilicus the urine can be poured out. This is the proximal part of the original allantoic diverticulum. It persists as a stalk called the urachus. Urachus is the remnant where this is developing, and from the bladder to the umbilical region. Urachus is represented when adults become fibrotic, so it is called the umbilical ligament. But if this umbilical ligament does not form the ligament, it stays patent. There is a lumen in this urachus. Then there is a, because it has a communication between the umbilicus and the developing urinary bladder, so urine may flow out from the umbilicus. The blood vessels of the allantoic stalk becomes the umbilical arteries, umbilical vessels, and have a separate origin. So this is going to become this, and this is going to develop in the region which is going to develop as the connecting stalk. Appears this pouch on the diverticulum of the wall. Small human embryo involved in early blood formation is related to development of the urinary bladder. Allantoic cysts, remnants of this between the fetal umbilical vessels detected by ultrasonography, proximal parts of the umbilical cord, because this is going to enter into the umbilical cord. This is the allantois. This is the part which is going to be the connecting stalk, where the chorionic cavity is not there. It's just where you are having the connecting stalk, which is going to become the umbilical cord. Proximal part of the umbilical cord near its attachment to the interior abdominal wall. Cysts are asymptomatic until childhood or adolescence, may prevent with infection. Fate. Now, when the intraembryonic mesoderm forms, there are certain cells, areas, what cells invaginate from the primitive pit, what cells from the primitive streak, center or sides, what part, because intraembryonic mesoderm has three components. One is the paraxial mesoderm in the center, then you have the intermediate mesoderm, and then you have the lateral plate mesoderm. These three plates. So fate map established during gastrulation. At this process, when there is invagination of the mesoderm, it is also then diagnosed, or it is determined that what part is going to go into the paraxial mesoderm. If you see this picture, you see these are the three parts. It's a better picture. You see this around the notochord, you have something collection of intraembryonic mesoderm. This is called your somites or the paraxial mesoderm. Then you have the intermediate mesoderm, and then you have the lateral plate mesoderm. I'll show you a better picture gradually as we show, right? So this is going to have three parts. So that is going to be determined when you have the gastrulation process. That is, the mesoderm is invaginating, that from what part it is coming, these cells, epiblast are coming as mesoderm, and what it is going to give rise to what layer. So epiblast that migrate ingress through the primitive streaks have been mapped out. That is their ultimate fate. Cells that ingress through the cranial end of the node, they are going to become precaudal plate and the notochord. Those migrating at the lateral edges of the node form the cranial industry, become the paraxial mesoderm. So that is those cells which go from the caudal cranial region of the node, they're going to form your notochord. That is from the ends, lateral ends of the node, they're going to become the paraxial mesoderm. Cells migrating through the mid-streak region, they're going to become the intermediate mesoderm, and through the caudal part of the streak, they're going to form the lateral plate mesoderm, that is towards the end. And cells migrating through the caudalmost part of the streak contribute to the extraembryonic mesoderm. So all these, from the pit, you have the cells which are going to become the precaudal plate and the notochord. Then from the edges, the paraxial mesoderm, or the somites, what we call, and they develop into the vertebral column. Then cells migrating from the mid streak, if you go backwards, in the mid streak region, they're going to become the intermediate mesoderm, and for the most posterior part, they're going to develop as a lateral plate mesoderm. And the most caudal part, contributing also to the extraembryonic mesoderm. Development of the somites. Notochord cells derived from the primitive node form the paraxial mesoderm. Paraxial mesoderm are ultimately called the C-shaped structure. They are thick and they are called the longitudinal column of cells, and these are called the somites. Each column is continuous laterally with the intermediate mesoderm. The lateral is continuous with the extraembryonic mesoderm. Paraxial mesoderm then condenses. So there are three parts of the intraembryonic mesoderm. That is, paraxial axis is your notochord. Cells of mesoderm on the sides of the notochord are going to be called the paraxial mesoderm. And this paraxial mesoderm is going to form blocks. And these blocks are ultimately called the somites, which are going to develop into your vertebral column. Then the mesoderm on the sides of the more laterally from the somites, that is going to be the intermediate mesoderm. This is basically concerned with your urinary system and all that is developing. And more lateral to it, near to your extraembryonic mesoderm, that is going to be called as your lateral mesoderm. And this, then the most outer end, that is going to form your and becoming continuous with the extraembryonic mesoderm. So these are the three parts which are going to give rise to different structures. Paraxial mesoderm condenses, divides into cuboidal bodies, the somites, and blocks. These are all located on each side. That is when the vertebral column is developing and the brain is developing. The somites are developing. About 38 pairs of somites formed during the somite period of human development, and the fifth, about starting from this, there are about 44 pairs at the end of this. And this is basically used, a number of somites is basically used for determining the age level of the baby. That is the period. The fourth and the fifth weeks are used as criteria for determining an embryo's age. And this is by counting the number of somites. There are fixed number of somites which have to be present at a certain age. That is going to be that we determine. So at roughly fourth and fifth weeks are used as a criteria, because that this number of pairs has developed by 38 pairs of forming during the somite period of human development. In the fifth week, 44 pairs have to be there of the somite. So that is roughly that the baby is fourth to fifth week age. Appear in the future occipital region of the embryo. They soon develop craniocaudally from above downwards. They're going to develop, giving rise to most of the axial skeleton. At the sides of the notochord and associated musculature, it's going to give rise to your bone, skeleton, and also to the musculature, which is adherent dermis to the skin. So all this area in the center. See in this picture, these are the somites start to appear in the midline, and then they're going to extend above and below. If you see this, this is paraxial mesoderm, intermediate mesoderm, and then the lateral plate mesoderm. These are the segments which are formed. This is the notochord, and these are the somites which are there. And these somites are going to number go from starting from the middle, and they're going to extend craniocaudally, and then they're going to give you the time period, that is what is 4 weeks baby or the 5 weeks baby. That is also the somite stage, because initially there are not so many features which have developed that you can say that this feature has developed. So it's by the age determination is done by the development of the number of the somites, the pairs of somites which have developed. Intraembryonic mesoderm proliferates between ectoderm and endoderm except central axis where notochord is formed. Differentiates into three parts: paraxial, intermediate, and lateral plate. Paraxial divides into the somites, lateral mesoderm divided by the intraembryonic coelom. That the way we had the extraembryonic coelom, a cavity is going to form. Somatic mesoderm between the ectoderm and the coelom. Splanchnic mesoderm between the endoderm and the coelom. You see this paraxial, red is the paraxial, which is the duct system, the somites. Then you have this intermediate, and then you have the lateral plate. This is going to develop into the urinary system. If you see this, a diagrammatic picture, you have the uh, neural tube with the cells on the edge, which are the neural crest cells, which are there on the margins of this neural tube. Below you have the notochord, you have the ectoderm, you have the endoderm. This is just a diagrammatic representation, so you understand what exactly is the picture. And then in the center is the mesoderm. This central mesoderm is going to form these collection of cells on either side, which are going to be called the paraxial mesoderm. This paraxial mesoderm is ultimately going to form blocks of mesoderm, what we call as somites. Then is the area which is next to it. That area of the mesoderm is called the intermediate mesoderm, if you see in this. And then if you go still laterally, that is the lateral plate mesoderm, which then further divides by this cavity formation, which is called the coelom, and it's going to again be called as the somatic and the splanchnic mesoderm, which is again going to become continuous with the respective. And then outer side, this splanchnic and somatic is going to become continuous with the extraembryonic mesoderm. The developing, how does the intraembryonic coelom develop? Mesenchymal cells form the primitive streak, migrate cranial each side of the notochordal process around the precaudal plate. Here they are going to meet cranially in front of the precaudal plate, and that area is going to be called as the cardiogenic area. If you see this picture, these cells are going to go forwards around the precaudal plate. See in this picture, this is the notochord. Notochord is the somite. Then this is going to go, these cells are going to go forwards. This is the precaudal plate. There the cells are going to go in front of the precaudal plate, and this is going to form the coelom or the cavity. This coelom or the cavity is ultimately going to become into your three body cavities, that is parietal, pericardial, and peritoneal cavity. Okay, this is in, that was the extraembryonic coelom. This is the intraembryonic coelom. Meet cranially to form the cardiogenic mesoderm in the cardiogenic area where the heart primordium begins to develop at the end of the third week. Intraembryonic coelom or the embryonic body cavity appears, isolated spaces appear in the lateral mesoderm and the cardiogenic heart forming mesoderm. These small cavities, the way we've said in the extraembryonic, these collect together to form a single horseshoe-shaped cavity, that is the intraembryonic coelom, and this divides the lateral mesoderm into two layers, as I have shown you this picture. This horseshoe-shaped, these are two. And the inner one is your splanchnoploric, and the outer layer is the splanchnoploric. So outer is somatoploric, and the inner one is the splanchnoploric. Right? So this develops into the cavity, intraembryonic coelom. Intraembryonic coelom formation during segmentation of paraxial mesoderm changes occur in the lateral plate mesoderm. Small cavities appear in the lateral plate, pulleys to form large cavity in intraembryonic coelom. The cavity is horseshoe shaped. Two halves on either side of the midline joined together cranial to the procaudal plate, as I've shown you in this picture. At first it is a closed cavity, but soon it becomes to communicate with the extraembryonic coelom. Divides the lateral mesoderm into two layers. When this cavity forms, again the way we had the extraembryonic and the the somatoploric and the splanchnoploric layers, again this intraembryonic is also going to be divided into by this coelom formation as somatic and splanchnic layers. During the second month, the intraembryonic coelom is divided into three body cavities: parietal, pericardial, and peritoneal. If you see this, the formation of the coelom, this is paraxial mesoderm, the intermediate mesoderm, and this is in the lateral plate. This is the coelom formation. When there is folding, these form on the cranial end. Extraembryonic coelom, this becomes continuous with the extraembryonic coelom. You see in this picture. This is the intermediate mesoderm, paraxial mesoderm, notochord. And then this lateral one that develops cavities. Cavities, they're first on either sides, and then on the either sides, they're going to meet together. And when they meet together, this is the cardiogenic area where it is going to form the pericardial cavity. Then it forms the pleural cavity, and on the sides, it is going to form what we call as the peritoneal cavity. And collectively, this all is called as the intraembryonic coelom. That is the cavity which is there in the intraembryonic mesoderm, and this becomes continuous on the sides with the extraembryonic coelom. Then the trophoblast is also developing at this area. Beginning of the third week, we said they were primary villi. That is the cytotrophoblast that invaginated into the syncytial trophoblast. That is these two layers of thing, they are called the primary villi. Then the mesoderm that enters into this cytotrophoblast, that is called the secondary villus. That means outermost is the syncytial trophoblast. Then you have the cytotrophoblast, and then the inner layer is the mesoderm. If you see this picture, this red is mesoderm, this green, light green is cytotrophoblast, and dark green is your syncytial trophoblast. These projections which are there, this is the secondary villus formation. Primary villus was without this red mesoderm entry. Cytotrophoblastic finger-like projection into the syncytial trophoblast, that was called as the primary villi. When the mesoderm added into the core of this primary villus, this becomes the secondary villus. Okay, and when blood vessels develop into this secondary villus, this is going to be called the tertiary villus. You see in this is a tertiary villus. These are the blood vessels they have formed. These are the villi. These are the tertiary villi, because in the mesoderm you can see the formation of the blood vessels. And if you see this picture, this is a primary villus. The core of this villus, that is the projection. Villus is nothing but a finger-like projection, with the outside is the syncytial trophoblast and cytotrophoblast is the inside. Then further it becomes the invagination of the mesoderm, that becomes three layers: syncytial trophoblast, cytotrophoblast, and mesoderm. This is called the secondary villus, and when blood vessels develop into this mesoderm, this is called the tertiary villus. Okay. So this is going to be ultimately a part of your placenta, the system, or the definitive placental villus, which is a portion of the villi foramen. This is all occurring. So at the end of the third week, what you see is this is the villi, the tertiary villi, that is syncytial trophoblast, cytotrophoblast, mesoderm with the blood vessels. So these are the tertiary villi, and this is going to be your outside is the chorionic cavity, and this is the connecting stalk. This connecting stalk with the blood vessels, this is going to connect with the baby on the other side. Capillaries in the tertiary villi make contact with the capillaries in the mesoderm of the chorionic plate. Chorionic plate was that which was there on the outer side and on the inner side of the cytotrophoblast, and in the connecting stalk. Let me show you this. This is the chorionic plate at the end on the outer side. Here, mesoderm of this in the connecting stalk contact with the intraembryonic circulatory system, connecting the placenta and the embryo. So all this is going to be connected when you talk about the placenta. Heart begins to function in the fourth week, and this is to supply the embryo proper. And this is the cardiovascular system is the first system to start into the formation. Then is the neurulation. Neurulation is the formation of the neural tube. Process involved in the formation of the neural plate and the neural folds, and the closure of the folds to form the neural tube constitutes the neurulation. We had the ectoderm. Ectoderm is going to form as the pit in the center, and that is going to form the neural tube. That the sides rise up, and that is going to be the neural folds. Neural folds fuse together and they form the neural tube, and only the ends of the tube, that is what we call as the neuropores, they are opening. Anterior neuropore and the posterior pore, they are still open. During neurulation, the embryo may be referred to as the neurula. If you see this depression, the flat plate becomes depressed in the center. These are the folds which are called the neural folds. This neural folds is then ultimately going to collect notochord, induces the overlying ectoderm to produce this development of the brain. You see this, it's flat. This becomes a developed fold in it, depression. This becomes a neural fold. The neural plate invaginates to form a longitudinal medial groove, that is the neural groove. Folds form at the cranial end and the signs of the brain development. At the end of the third week, folds begin to move together and fuse, and the neural folds approach each other and forms the neural tube. The fusion is complete. Cephalic and caudal ends of these tube are open. They are called the neuropores. That is, there is an opening by the anterior or the cranial neuropore and posterior or the caudal pteronode, and the rest is the neural tube. Closure of the neuropores occur approximately. Anterior closes by the 25th day, and the posterior closes by the 28th day. You see in this picture, these are the folds which are formed: flat plate, neural plate. Neural plate has a depression in the center, folds rise up. These are the neural folds. Neural folds start to fuse in the center, going from front backwards, and this forms the neural tube. The ends of the neural tube, they are open. These are called the neuropores, the anterior and the posterior neuropores. As you can see, the tube has started to join, but this is the anterior neuropore and posterior neuropore. With this, it is linked up with the neural cavity, the amniotic cavity. The neural crest cells, where these cells fuse together at the edge of the neural tube, you have these cells which are called the neural crest cells. They leave the neuroectoderm, enter the underlying mesoderm. These crest cells from the trunk region leave the neuroectoderm after closure of the neural tube, migrate on the sides. I'll show you. This is when the tube is forming, the neural groove, then the neural folds, tube is formed. Then the cells on the edge of this neural tube are called the neural crest cells. These neural crest cells gradually they move to the sides. If you see on this picture, on the sides of this, and then they are going to of the neural tube, and they are going to form the developing spinal ganglia. Right? These are rest of the leave the neuroectoderm after closure of the neural to migrate along to pathways through the dermis. They will enter the ectoderm to form also the melanocytes. We'll talk about what all is going to develop from the neural crest cells. Neural crest cells, derivatives, long list you have to remember because you can get a full question. So this is the formation of the neural tube, the neural crest cells, what all forms. And if you see this, this is paraxial mesoderm, intermediate mesoderm, and lateral plate mesoderm. This forms the neural folds. These are the edges. Neural tube is formed. Edges of the neural fold tubes are called the neural crest cells. These neural crest cells, they migrate onto the either sides, and this is going to give rise to your dorsal root ganglion. See this? They're going to form the different ganglia for the different pharyngeal arches. Neural tube defects. The disturbance of the neurulation results in severe abnormalities of the brain and the spinal cord. Neural tube defects are the most common congenital anomalies. Failure of the folds to form and form the neural tube. Meroencephaly, that can occur. Absence of brain is most severe. Anencephaly, no brain at all, that's not possible because small amount of the tissue is there. If closure fails anywhere from the cervical region, it's called the spina bifida. That is, the vertebral column basically is bifid and this brain is protruding out. I'll show you a picture. Children with spina bifida lose a degree of neurological functions based on the spinal cord lesion and the severity. Various genetic and environmental factors account for this variability. 70% of the defects can be prevented. That is the neural tube defects. Women take 400 microgram of folic acid before they start to plan a family because it is said to prevent the neural tube defect. So the prevention can be done by taking 400 microgram of folic acid beginning 3 months prior to conception and continuing throughout pregnancy because that prevents the neural tube defects. This is anencephaly, no brain development. This is spina bifida, that is the vertebral column has not fused and then the brain is protruding out, the spinal cord is protruding out of it, and this is called the spina bifida because basically this is the problem in the spine. And then this is then inshallah in tomorrow's class we're going to talk about the next, and that is the starting of the development of the blood vessel. So this was about the third week. We are going to continue some portion of the third to the 8th week and then the fetal period. Okay ji, thank you. I hope you have collected what we have done because this is many things are simultaneously going on.